Okay, let's talk about gastrointestinal issues. So the first one we're going to talk about is nausea and vomiting. At least here's one topic that everybody can relate to, they've had, they've seen, they know about. So, um, you know, nausea and vomiting is the body's way to get rid of stuff. Say it's not working, I don't like it, something's going on, it's a sign of maybe something else that is happening. A few times now and then is okay. It's when patients have protracted nausea and vomiting that is a problem. They can become dehydrated. They're going to be losing electrolytes. So over a long period of time, doesn't take that long, you're losing your potassium, sodium chloride. So a patient's going to become metabolic alkalosis, thinking of it that you're losing all your hydrochloric acid from the stomach. So you become metabolic alkalosis, lose all your acid. So different kinds of things that we see with vomiting is, number one, you're going to have what's called regurg. Regurg is usually you don't have any vomiting, you don't retch, it just is going to precede vomiting. So when bile and vomit comes up into your throat, into your esophagus, that's regurg. You usually don't vomit, but it comes up. Um, Next is projectile vomiting. It's very forceful vomiting. Usually you don't have nausea with projectile vomiting. It just happens. You don't feel sick, you just vomit. And it's very forceful. It can, go all the way across the room if you were standing up. Sometimes it can be caused by just a really strong irritant. Very common with brain injury patients. If all of a sudden they have projectile vomiting, is there a brain injury going on, a brain tumor, something like that? Bile is it's usually what is formed in your stomach, your duodenum. Bile comes down from your gallbladder. It's liver bile stored in your gallbladder, comes down, gets into your duodenum. So if you have a bile obstruction, that can cause nausea and vomiting. So partially digested food, if it's green, very alkalotic, could look like bile, green, yellow, bile-ish. It's a lot different than just digested food when the patient vomits. So is it important to know early morning? People vomit morning sickness, early morning or after a meal. And also the other thing we assess about vomiting, which is important, is the appearance, the color of the emesis. Emesis is a fancy word for vomit. So if it's coffee ground appearance, then that will tell us that it could be old blood that's already been partially digested. Old blood is not near as serious as bright red blood, which is current bleeding. Bright red blood or frank blood. Green, yellow could be the bile. So, what color is the emesis? Is it new blood? Is it old blood? Active blood? Bile? So acute nausea and vomiting, vital signs. Is the patient dehydrated? Labs, have they become alkalotic? So if you're dehydrated or deficit volume on board, what kinds of signs and symptoms would you expect from the patient? What would you expect? Well, different things. So think back when we were talking about dehydration, what kind of things would be expected? What might you see? So some people believe in a lot of complementary therapy. Some people think it helps, others do not. So nausea and vomiting, there's a lot of different ideas out there. Peppermint oil, smelling peppermint oil will take away nausea. Ginger, people drinking ginger ale, they think that will help nausea and vomiting. Acupressure, lots of times if someone feels nauseated, you tell them to take a deep breath through their nose. That sometimes helps the nausea go away. Cool washcloth on the forehead, not having a lot of sensory stimulation in the room. Some patients nurses believe if you open up a alcohol swab and have the patient smell the alcohol in the swab, that will help take away nausea. Lots of different things out there. So drug therapy, there's lots of different drug therapies for anti-emesis, antiemetics. So here's a whole list of them. Do you know what kind of medications fall in each category? Do you know what would be if the doctor says we need to give them a phenothiazine or an antihistamine? Antihistamine's easier. Benadryl is an example of an antihistamine. How about a Prokinetic, Anticholinergic? All of these are classifications of drugs that will aid in nausea and vomiting. So nutritional therapy during nausea and vomiting. Probably the best thing a patient can do if they're vomiting is stay NPO. If you put anything on your stomach, you'll probably vomit. Don't put anything on your stomach. If they have an NG tube in down their nose and in their stomach, NG tubes usually is on low intermittent suction. Could be on low continuous, but let's keep the stomach empty so they won't feel the need to vomit because the stomach has fluid on board. If they are vomiting a lot, they are probably going to need IV fluid, so electrolytes, glucose, isotonic fluid, maybe D5, normal saline, something like that. Lots of times patients have reactions with hot and cold beverages. If it's hot or cold, it may cause a patient to vomit. Otherwise, just tepid, room temperature, tepid fluids. Ice chips, sips over big gulps sometimes help. Patients that have been NPO for a long period of time for nausea and vomiting, let's start them on ice chips rather than big gulps of fluid. That might help the patient. Low carb diet, getting back after NPO and vomiting is better than fatty foods. Fatty foods tend to stay in your stomach a lot longer. They don't go through as quicker as carbs. Clear liquids, cola, sometimes people think that will help. So bland foods to begin. Think of the brat diet. Don't have to go on that, but you're talking about toast and rice. Things like that are easier on the stomach. Nursing diagnoses, obviously deficient fluid volume and loss of nutrition. So gerontologic factors for somebody with nausea and vomiting. Well, the big factor is if they're losing fluid, they have decreased LOC. And just because of gerontological factors, the patient's at a higher risk for aspiration if they have decreased LOC. Some patients, because of the antiemetic drugs, that will cause a CNS change or an LOC change, those medications. Giving somebody Benadryl might be a great idea if they're 85 years old, but that Benadryl may cause the patient to become very loopy and confused. Renal issues. If the patient's losing a lot of fluid and electrolyte imbalances, do they already have renal dysfunction and insufficiency? That might be an issue. GI bleed. GI bleed is a big factor. A lot of patients have GI bleeds and it can cause lots of complications. You can either have an upper GI bleed or a lower GI bleed. Upper GI bleeds, if they're going to vomit, they're going to vomit bright red blood. If it's coffee ground emesis, means it's old blood. GI bleed, when that blood works through the GI, the patient will have melena, or black stool as it's called. They might have slow bleeding and you can't see it in the stool. It's not frank blood. They don't have melena, but you have to do a guaiac test. You can do a guaiac test on a patient's stool for occult blood, or you can do a guaiac test on a patient that's vomiting and has tiny amounts of blood in it. So you could have guaiac positive emesis, guaiac positive stool. So causes of upper GI bleed. Well, it could be a myriad of things. Most commonly, it could be because they have an ulcer. So Gastric duodenal ulcers could be an issue. Patient could take too many medications, too many aspirin, can cause a GI bleed. Medications that are irritating to the stomach, that can erode the stomach lining. Could be the bleedings coming from the esophagus. Maybe they have varices, esophageal varices, bleeding from that. It could be from some systemic disease. Maybe the patient's bleeding because they're taking Coumadin for a reason. The Coumadin's too high and it's causing a GI bleed. There could be other reasons. So causes of upper GI bleed could be a myriad of reasons. Could be trauma. So stomach or duodenal origins of GI bleed. 50% of all GI bleed, upper GI, is caused by an ulcer. Was it caused by NSAIDs, aspirin, or do they have Helicobacter pylori, which is a bacteria that can cause stomach ulcers, gastric ulcers? Most of them, this is where they're at. So what do you want from an outcome as a nurse from a GI bleed? You want the patient to stop bleeding, no bleeding. You want them to be able to maintain normal fluid volume, get back to normal hemostasis in their fluid, return to normal hemodynamic state, meaning their blood pressures in the normal range. Need to understand factors that caused it, make changes in the diet, the lifestyle. Maybe the patient's drinking a lot, different things. Other things with patients with GI bleed, you don't see it as much, but gastric lavage, meaning you're lavaging down an NG tube to get to bathe the stomach in fluid, suction back out, so gastric lavage. If you're doing a gastric lavage on a patient that tried to OD and there's still pills in the stomach, gastric lavage, the pills might become stuck in the suction tube. Surgical treatment. Well, if you can't stop the bleeding by normal means, giving blood, if the patient needs platelets, if the patient taking away the mechanism that's causing the bleed, such as stopping the alcohol, stopping the drugs, patient may have to have surgery because of the bleed. Obviously, if you lose too much blood, you're going to go into shock. So you don't want the patient to go into shock because of too much blood loss. If they need lots of blood, then you may have to do rapid transfusion up to 2,000 mLs. It's very fast infusion of blood. Age of the patient. Patients that are elderly and infants, toddlers are going to react quicker to blood loss than a normal adult. Where is the hemorrhage as well? Where's the hemorrhaging happening? Sometimes they might have to have surgery because of the GI bleed. So if things don't work, we'll probably have to go to surgery. So tests that we can do before we do surgery if someone has a GI bleed is we can do an esophago-gastro duodenoscopy. Let's find out where the bleed is and let's do something about it. So how do we do an EGD? Upper endoscopy or an EGD or an upper? Well, we talked about this some time back very quickly. So patient prep, what's the role of the nurse in here? Somebody that has a EGD or an upper endoscopy, it's an invasive procedure. We need to use conscious sedation. Patient needs to have IVs, needs some baseline vital signs, need to be on some oxygen because we're giving them conscious sedation. We need, as a patient's role, you're going to be giving them medications. We may need to tie the patient's hands down. Patient needs to sign a consent unless it's emergent. Patient's going to have a bite block to do this procedure. They usually don't take very long, but during the procedure, with the camera on the scope, the doctor can find the bleed, and perhaps using heat, they can kill the bleeding spot. They could use epinephrine to freeze the spot. Another thing is argon plasma coagulation. You don't hear that one that much. It's usually the freezing or the epinephrine. They inject with epinephrine. If there's varices and they can grab enough in the esophagus, if that's where they're bleeding, they can like put a rubber band around it. That's called a ligation. Sclerotherapy is using the epinephrine. So epinephrine's 1 to 10,000. After an upper GI, if the patient had bleeding, upper GI bleed, we put them on octreotide. Notice it's a statin drug, but it's not a lipid-lowering drug. This actually reduces blood flow and acid secretion, helps the patient heal quicker. Patient may be on antacids, maybe that'll help. Put them on H2 blockers, put them on proton pump inhibitors, anything that's going to help the patient heal from the GI bleed or something that's causing GI problem. Which leads us into our next topic, which is GERD, gastroesophageal reflux disease.